Hello, I'm Angela Hogan from Norfolk, Virginia. The title of today's lecture is Slow, Children at Play. These are my disclosures, and they will in no way impact the subject of our lecture today. As a result of attending this session, I hope that you'll be able to distinguish between the different presentations of difficulty breathing while exercising, and I hope that you'll be able to utilize those presentations and diagnostic studies to adjust therapies in order to optimize the performance for the child athlete. Exercise is critical. According to a National Health Service website in England, it has many health benefits. Most notably, it can lower the risk of multiple diseases, including coronary artery disease and stroke, type 2 diabetes, colon cancer, breast cancer. It also has improvement for how our bodies function in terms of reducing the risk of fractures and falls. And it also is important for our mental health. It lowers the risk of depression and dementia. Exercise is essential to help control weight. It helps combat health conditions and diseases, as we just mentioned. It improves your mood, it boosts energy, it promotes better sleep, and exercise can also be fun and social. Most people use the term exercise-induced asthma and exercise-induced bronchospasm interchangeably. But is one term better than another? Well, many experts would feel the term exercise-induced bronchospasm is the better term to use. Exercise-induced bronchospasm describes the phenomena, the transient airway narrowing that occurs during or after vigorous exercise. It's a more accurate reflection of the underlying pathophysiology. Exercise-induced asthma is not preferred because exercise is really not an independent risk factor for asthma. So what is EIB? Well, EIB's prevalence is between 5 to 20% of the general population. Up to 90% of symptomatic asthmatics will have some exercise-induced bronchospasm because their asthma is not well controlled. In asthmatics, the more hyper-responsive the lungs are and the more inflammation there is in the airway, the greater degree of exercise-induced bronchospasm there will be. So let's discuss the pathophysiology of exercise-induced bronchospasm. When we exercise, we breathe more rapidly, and this is called an increase in the minute ventilation of the lungs. The volume of the air that is moving in and out of the lungs is moving more rapidly. This rapid breathing often causes individuals to change from breathing the air in through their nose to breathing the air in through their mouth. And by breathing it in through their mouth, that actually does not allow the air to get moistened and have a temperature adjustment that normally happens in the nose. Instead, the air becomes more dry, and that changes the surface osmolality in the lungs, and that leads to bronchoconstriction. We also know that the exercise process does in fact increase some inflammation in the lungs. We see increases in inflammatory mediators like leukotrienes and histamine, and also some cytokines. There's also an influx of eosinophils that is a good indicator of increased airway inflammation. But nitric oxide is not a good marker for airway inflammation. It doesn't seem to be affected at all with exercise-induced bronchospasm. What are the most common symptoms? You know these well. Coughing is actually the most common symptom, but sometimes we hear wheezing. Commonly, patients will complain of tightness in the chest or prolonged shortness of breath. There can also be increased mucus production. They often complain and say they can't run more than just a few minutes before they have to stop because of the increased symptoms. They get tired when they're running very quickly, and very commonly they're not able to keep up with other kids. So let's talk about the EIB timeline and the symptoms that we see with exercise-induced bronchospasm. So initially, when you begin intensive aerobic exercise, in the first 6 or 8 minutes, we actually see bronchodilation that occurs. And then as you continue to exercise, or even if you stop, within about 15 minutes of this initial exercise period, then we can see exercise bronchospasm symptoms develop. We usually see resolution of those symptoms at about 20 to 60 minutes. And if you are a well-conditioned athlete and are able to continue to run or do intensive exercise beyond those initial minutes, then sometimes you can appreciate a refractory period where you won't have any additional exercise-induced bronchospasm for about 4 hours. These are some examples of sports and their potential risk for exercise-induced asthma. And it has to do with what's the environment that you're playing the sport in and what's the intensity of the sport. So, for example, all of us would believe that if you were a marathon runner, that potentially that would be a high risk for a sport for having exercise-induced bronchospasm, or if you were doing cross-country skiing out in the cold air, then the cold air would help strip the moisture from the airway and induce the bronchospasm, so that would be considered a high-risk sport. These are sports where the athlete performs for several minutes in a dry or cold environment. On the opposite end of the spectrum, low-risk sports would be sports where you don't have to do as much exertion. These might be things like golf or potentially weightlifting or swimming, where there are more spurts of activity. And then medium risk might be sports where you have to run for a longer time period, potentially like basketball or soccer. So with exercise-induced bronchospasm, there are some factors that can be additive and make the exercise symptoms a little more prominent or a little bit worse. For example, we know that in individuals who are allergic, if they exercise in the environment where their allergens are present, then they can have increased exercise symptoms. This might be the example of the kid who is allergic to grass pollen, and they are playing soccer in the soccer fields that were just freshly cut. We also know that air pollution can cause increased exercise symptoms. It has to do with the size of the particulate matter, and those in combination with being in an urban area, or perhaps maybe the ice polishers that put a lot of small particulate matter in the airway, that can increase the exercise bronchospasm. We also know that irritants can play a role too, and this is most commonly seen, for example, in the kids who swim or who dive and are in pools that have very high chlorine and nitrogen compounds that have a significant irritant component. And then we also know, obviously, as we mentioned just a moment ago, what temperature you are exercising in and whether the air that you're exercising in has low humidity. Those are things that can also cause increased bronchoconstriction. So let's look at some examples. So the first story that I want to share with you is the story of Jenny. Jenny is a 16-year-old female who presents with chest pain during exercise. Her symptoms developed about 2 months ago. She described it as mid-sternalish. She described it as pressure. It occurred after she had to run suicide drills. Further history revealed that her symptoms seemed to start about 10 to 15 minutes into exercise. There was some shortness of breath. She had trouble getting air both in and out. She was not dizzy. She did have a history of allergic rhinitis symptoms. She did not use albuterol in the past. And it seemed to be a little bit worse this past week when there were some college coaches watching her play basketball. So what is your differential diagnosis for Jenny? Well, obviously she could have baseline asthma that's just poorly controlled. She could have laryngeal obstruction. This is the entity that we formerly called vocal cord dysfunction, and then paroxysmal vocal cord motion disorder, and now it is called exercise-induced laryngeal obstruction, or ILO for just inducible laryngeal obstruction. She could have exercise-induced laryngeal malacia that is causing abnormal closure in her throat. She could have potentially exercise-induced anaphylaxis. She could have some sort of cardiac findings. She could have reflux that's associated with exercise. She could have hyperventilation or possibly even deconditioning. So how do we diagnose what symptoms are going on with Jenny? Well, the diagnosis of exercise-induced bronchospasm is one that's based on clinical symptoms and also on demonstrating reversible airflow obstruction in response to exercise or a surrogate challenge. The easiest thing to do is actually do an empirical trial of a bronchodilator like albuterol before exercise and see whether or not it seems to help. But the more formal diagnosis can be made with exercise testing, usually in a pulmonary function lab. We oftentimes do this in patients that either have asthma or maybe have never documented asthma ever. We put them on the treadmill. They run at a high level of intensity for 6 to 10 minutes. We measure their lung function before they start and then throughout the course of the exercise. And then we also measure it after they stop exercising to see if they have a fall in their lung function. And the gold standard is that if you have a drop in your FEV1 of about 10 to 15%, then that's considered a positive exercise challenge. But sometimes in the lab on a treadmill where the air is regulated, it may not be the best way to diagnose exercise-induced asthma or bronchospasm, especially because it may be important role of the environment is not taken into effect there. So sometimes we do field testing with devices that can give us serial measurements that will help us understand what happens when they're actually in the situation. So some of the devices that are available on the market are a MicroLife or an Illuna device that can be purchased. And I have sometimes patients that I will say, go and take measurements while you're playing ice hockey so that we can see whether or not you have a drop. What we do know is the good old-fashioned peak flow meter, however, does not seem to be a very useful device. It does not give us a lot of information. It's really just too crude. The measurements aren't sensitive enough to be able to pick up a fall in function. There are some other tests that can be done. Methacholine challenges sometimes can measure airway hyperresponsiveness and help us diagnose asthma, but they don't necessarily tell us whether or not they're having exercise asthma. We sort of can deduce perhaps maybe if they have undiagnosed asthma, then they might be having exercise asthma also. And then there are some other tests that are more complicated that we don't traditionally use. But many times I have sent people to the field and said, take measurements while you're there, and that may help us diagnose it a little more easily. So back to Jenny. So Jenny's physical exam was normal, including her lungs and her cardiac exam, and she underwent spirometry. And just to review quickly for her spirometry, her FEV1, which was a measure of her large airway numbers, Her pre-bronchodilator was 93%. After 4 puffs of albuterol, she improved to 108% for a 16% change. So the lung books normally say that if you have more than 12% change, that is considered airway obstruction or significant or asthma. We can look here that she did have a slight improvement in her lung volume. And additionally, when we look at her small airway disease, or small airway numbers, her 25-75, she was initially 82%, post-bronchodilator 135% for a 63% change. And that is a significant change. Most people feel that if you're more than 25%, that is a significant amount of reversibility. So in this particular case, Jenny was started on a daily inhaled steroid, and she was told to pre-treat with a short-acting beta agonist using a spacer before she exercised. So let's spend just a moment and talk about what are some non-pharmacologic measures that can be used to treat patients that are having exercise-induced asthma or exercise-induced bronchospasm. The most important thing we want to make sure that kids keep exercising. Sometimes I'll have moms who are so concerned about the symptoms that their child may have that they ask me for a note to get them out of PE or keep them inside during recess. And I try very hard not to do that because, again, exercise is very important for all children. So in the case of children who have asthma, make sure that you're treating the underlying asthma, and that in and of itself, as you saw, will help improve their exercise-induced bronchospasm too. But as we mentioned, there are some additional things you can do, like trying to avoid triggers, making sure that they don't exercise in the cold. And if they do have to exercise in the cold, oftentimes I will have them use a scarf, or most recently a mask would work too. And by breathing through that particular piece of cloth, it will actually help warm the air and also increase the humidity of the air, so we're less likely to see bronchospasm. We obviously want them to exercise in an environment where there are not a lot of irritants or poisons. Obviously, the quality of the pool water is very important for swimmers. It's also been shown, though, that if you warm up prior to exercising your sport or your intense period of time when you're exercising, that those warm-ups may actually be helpful to reduce the amount of exercise-induced bronchospasm. And additionally, we need to tell our athletes to breathe through their nose, again, because breathing through the nose helps warm the air and moisten the air, so it's less likely to cause the bronchospasm. We tell players to drink a lot, and there's a good reason for that, because that actually helps put water back in their body and also make water available for their airway, so that they're less likely to have the bronchoconstriction also. So we usually recommend that they drink at least 8 ounces of water prior to exercise, and then 8 ounces for every 30 minutes of prolonged exercise. And then there are some studies that suggest in athletes who are very serious about their sport that sometimes you can make some dietary modifications, like maybe omega-3 fatty acids increasing in the diet can be helpful, reducing the amount of salt in the diet, and also high vitamin C in the diet has also been able to blunt some of the exercise-induced bronchospasm. So we've tried all the pharmacological measures. They have improved their environments. But we feel like we're going to need to use some medications. What are the standard medications we use in the management of exercise-induced bronchospasm? Number one would be a short-acting beta agonist. And it seems to work best if we use it between 5 and 20 minutes prior to exercise. The effects of it last for about 3 hours, but about 20% of individuals who have short-acting beta agonists on board, they get incomplete protection. Alternatives to short-acting beta agonists, as we know from GINA guidelines and also from the new asthma guidelines, can be the combination product budesonide and formoterol, and it is also given 5 to 20 minutes prior to exercise. And then leukotriene receptor antagonists like Singulair can also provide some protection. They usually need to be taken about 2 hours before exercise in order to get the maximal benefit. They also accelerate the post-exercise recovery period, and the protection from that medication can last up to 24 hours. But they're not advantageous by themselves. They would be an additional medication that you would add after you are already on the short-acting beta agonist. So let's talk about some additional pharmacologic measurements that can be used to treat exercise-induced bronchospasm. You can additionally add an anticholinergic that has been shown to be very helpful. What it actually does is it has its onset of action in about 15 minutes. The peak effects are usually within 1 to 2 hours, and it can reduce the drop that we see in FEV1 with exercise. Additionally, if you could get your hands on mast cell stabilizing agents, they can be very helpful. They're able to completely block exercise-induced bronchospasm, but they're not available in this country anymore. You might be able to still get them from Canada, and they were previously shown to be very effective, at least for this entity. There is the discussion now about ICS and long-acting beta agonist. Certainly, I mentioned on the previous slide that formoterol and budesonide is now being used as a bronchodilator with an inhaled steroid addition. But if you have a patient that's on a different ICS LABA product, they can also see improvement with their exercise-induced asthma, not in the immediate effect, but the effects of the medication throughout the day has been shown to decrease some of the EIB. We don't ever use LABAs by themselves. We know that if they are used regularly by themselves, then we can see tachyphylaxis, and then they become much less effective. And also simply treating the asthma and improving the underlying airway hyperresponsiveness and inflammation is a good role for inhaled corticosteroids or treating the asthma itself, and that can also reduce EIB. So here's Jenny 6 weeks later. She has seen some improvement in her exercise overall. She's been pre-treating before basketball, but there are still times when it isn't enough. In her most recent game, she had a cough and then seemed a little hoarse when she was yelling for the ball. Her symptoms escalated, and she felt as if she were acutely air hungry. She motioned to come out of the game and used her albuterol, and it worked within about 20 minutes. With further history, I asked her when she was having her most difficulty, and she said she was having the most difficulty getting air in, and this time she actually pointed more to her neck and said that that was where she was having her more discomfort. So what study do we want to do now? Well, the next appropriate study would be go ahead and do an exercise study. In her case, she's previously been diagnosed with asthma. We have her on a controller medicine. She's pre-treating, but she's still having breakthrough symptoms, so we don't know what's going on. So an exercise study would be appropriate. So there are several things now in Jenny's story that make us start to think about, could she possibly have vocal cord dysfunction or inducible laryngeal obstruction? As you know, when we breathe in, our vocal cords are normally supposed to be open so that we can get air in, but in inducible laryngeal obstruction, what actually happens is we have abnormal adduction on inspiration of either the true vocal cords or the false vocal cords, and it creates an obstruction for our ability to breathe in. So key questions that you want to ask patients in exercise-induced laryngeal obstruction or EILO is, are you having trouble getting air in or getting air out? In patients that tell you they're struggling to get air in, then you should be thinking about ILO. And then also, if you can ask them where they feel like they're having difficulty breathing, that can be an additional clue. In patients who are having ILO, they seem to be having more difficulty up here in the neck area of being able to get air, and asthma tends to be difficulty getting air a little lower, more sternal, and also can be both in and out part. Things that you can see with ILO is you can hear stridor sometimes. You might even hear loud wheezing. They complain of shortness of breath. Sometimes they just cough, and that's a sign of their ILO. And then many times they will tell me that they may feel profoundly air hungry. I had one patient describe it as if someone were holding a pillow over their face and they were trying to breathe and get air through the pillow. This is a specific impaired function, and it's not a psychosomatic type of illness. What we know about ILO is that it affects between 5 and 7% of young adults and adolescents, and exercise is a very common trigger for it. It seems to me more common in female athletes who present with shortness of breath with exercise. These are usually my very competitive perfectionists that are very driven, and oftentimes it will surface during high stakes competitions like college coaches that may be coming to watch them during soccer or basketball games. And sometimes, again, the role of irritants is an important combination along with the exercise. As I mentioned, the soccer player playing in the field where there's fresh cut grass. So, again, what is the clinical presentation of ILO? It's throat tightness. Sometimes they'll even say they have a choking sensation, or they feel like something may be stuck in their throat for a brief time period. Cough is very common. Sometimes they may describe reflux type symptoms, and reflux can also cause ILO. And sometimes they also complain that they may even have a little bit of difficulty swallowing. When exercise is the cause of ILO, the onset of symptoms is usually when they are at their peak exercise, unlike exercise asthma, when the exercise symptoms are usually after peak exercise. You may actually hear stridor, but oftentimes you don't, and the patients oftentimes report that they can actually hear themselves wheezing. And albuterol does not seem to have a very significant effect at all. And in the case of Jenny, if you remember, she said she came out of the game and she used her albuterol, and it took 20 minutes for the albuterol to have any effect. And as you know, we expect albuterol to start to work in probably 5 or tops 10 minutes. And also, sometimes patients who are having ILO have a hoarse voice or a little bit of difficulty speaking when they're having the attack also. So this is a slide here that demonstrates for you a little bit of the differences between the two. And what you can see here is that exercise-induced bronchospasm tends to happen after the peak exercise has occurred and can occur up to 30 minutes after the exercise. With exercise-induced laryngeal obstruction, again, it happens during the peak point of the exercise. And also the location that we see the symptoms is different between the two. So, again, how would we diagnose it? Well, the gold standard is to do an exercise challenge and then be able to also look at the chords at the same time that they are exercising so that you can see the adduction occur while they're having peak exercise. But that's a little bit tricky to do. If you can do spirometry and capture it at the time that it is occurring, then that can be also helpful. But many times you don't capture it at the same time. If you do happen to capture the ILO at the time of the spirometry, what you see here is this flattened inspiratory loop as opposed to this normal well-rounded loop on this normal study here. And what we also know is that the effect of the blunting can be pretty profound, and that you may see it be intermittent also. How do we usually treat these kids? We usually send them to speech pathology. In my hospital, speech pathology usually tries to provoke it so that the patient can say, yes, that's what I feel. And then they teach them a series of breathing exercises that actually helps them kind of capture their vocal cords, make them behave, and they start those breathing exercises whenever they feel the symptoms coming on. In some individuals, more extensive therapy may be needed if the episodes are very persistent. Sometimes we have patients who have a lot of recurrent episodes even after having gone to speech therapy. In some of those individuals, we may use biofeedback or maybe do some psychological counseling. I have had a few patients where we've actually paralyzed one of the vocal cords so that it's unable to move, so they can't get a full adduction. And the effects of Botox oftentimes will last 2 or 3 months, and it'll give us an opportunity to try and address the ILO from some other method or way in order to reduce the frequency of their episodes. If you don't have a speech pathologist handy, one of the quick and short exercises that I usually recommend is a sniff, sniff, breathe out for 4 with kind of pursed lips. So it's a sniff, sniff through your nose and then blow out through your mouth, a little bit like Lamaze type breathing. And you're going to blow out for 4 seconds and then sniff, sniff, and then blow out again for 4 seconds. And sometimes if you do that exercise for a couple of minutes, you may be able to make your vocal cords behave a little better. There's also something called dysfunctional breathing that was also in our differential diagnosis of Jenny. And these are individuals who might do hyperventilation, where they do a lot of very rapid minute breathing, and because of that they may get very lightheaded. These individuals oftentimes have a lot more anxiety. They also get paresthesias, maybe their fingers and toes feel very numb and tingly. And this particular syndrome of dysfunctional breathing or hyperventilation usually is more clear-cut based on their history. They have a normal exam and they don't have any other positives when you try to work it up further. If they have many recurrent episodes, then oftentimes we have to send them to the psychologist or the psychiatrist for some additional anxiety improvement so that they have less episodes. The main way that we treat dysfunctional breathing is reassurance and try and calm them down. We don't use paper bags anymore. Back in the day when I was in elementary school, we used paper bags, but that's not recommended anymore. There's concern that that may make the individual hypoxic and that they may also rebreathe too much of their carbon dioxide. So we don't advise that. And then the other thing that was on the differential diagnosis for Jenny was deconditioning. Is Jenny out of shape? So obviously, probably if she's functioning at a varsity athlete level, the odds of that are a little bit lower. But this can be very challenging from a diagnostic perspective. There's no widely accepted criteria to actively be able to diagnose it. These are individuals that have shortness of breath within minutes of exercise, and they usually don't have wheezing or stridor. These are the kids that are very reluctant to exercise, and when we do pulmonary functions on them, they have stone cold normal lung function, and they don't demonstrate reversibility following albuterol. Out of shape individuals can catch their breath within minutes, whereas it takes much longer for someone who's having exercise-induced bronchospasm to actually recover, and that may in and of itself be something that can be helpful. These are the kids that run and they say, oh, I'm fine if I stop, and then I'm okay almost immediately. But the diagnosis of deconditioning doesn't exclude other diagnoses, and certainly deconditioning can be on top of exercise-induced bronchospasm or ILO also. So here's kind of a flow chart that I think is helpful on how do you proceed. If you have someone who has symptoms suggestive of exercise-induced bronchospasm, the first thing that I would do is give them a SABA and see if it helps. And if it does, then they can continue to use it. And if they need to use it frequently, then I might think about whether they have underlying asthma that needs to be treated. If they have not a very good response to it, or they don't have any response whatsoever, then I probably would move ahead and do an exercise challenge. And if the exercise challenge does in fact confirm exercise-induced bronchospasm, then I would think about treating them in both non-pharmacologic and pharmacological ways that we just talked about. And if the exercise challenge is non-diagnostic, then I start to think about other diagnoses such as deconditioning, or possibly if they really do have inducible laryngeal obstruction, but I just didn't capture it at that particular time when they're exercising. So if the SABA doesn't work, what else is going on? So I want to share with you a study that I thought was very helpful. This study was published in 2014, and it looked at some French children who over an 18-month period had shortness of breath during exercise. They had normal spirometry, normal chest x-rays, and they all had been given albuterol, but they had not had a response to the albuterol. So this was the population. There were 79 children in the study, and their mean age was 12, and 49 of them had been previously diagnosed with asthma, but they either had no asthma further, or they were considered to be well controlled with their asthma. So in this particular study, they underwent exercise challenges on the treadmill, and they looked at multiple different parameters to determine which profile they fit under, and spirometry was performed multiple times. And what they found is that in the patients that had a previous diagnosis of asthma, there were 49 patients, and those without a previous diagnosis of asthma, there were 30 patients. And then they looked at what was the frequency of the different diagnoses. And what they found overall in this group is that 67% of them actually had normal exercise symptoms, normal physiologic responses, and that a very small number of them had ILO, only 2 of them. There were a few patients, I think a total of 17 between the two groups, that had exercise-induced asthma, and there were a few patients that also had hyperventilation syndrome between the two. But what was the most important finding was that 67% of them had a physiological normal response during exercise, that they got short of breath because they had exerted themselves, and that was what was considered to be normal. And only 22% of them had exercise-induced asthma, despite reporting no protection from the short-acting beta agonist. So the conclusion was the most frequent finding in children and adolescents with mild exertional dyspnea unresponsive to SABAs is it's a normal physiological response to exercise. And in this particular study, they did ahead and did an intervention where they gave them reassurance, and they saw improvement in all of their exercise quality symptoms. So what are the best exercises, again, for someone with asthma? Again, activities that involve short, intermittent periods of exertion are the best. You should avoid cold weather. Swimming may actually be a very good sport for individuals with asthma if the water is not too polluted with chlorine and those other ingredients that are added to the pool water. And part of that is because the humidity right at the surface level where they're swimming is very high, and that allows their airway not to have the moisture stripped off of it. And it's important that we remind everyone that an active lifestyle is still important, and that we find the best exercises. And there are individuals who have asthma that have gone on to be great Olympians. Data from the last 5 Olympic Games reveal that about 8% of the participants in the Olympics worldwide do have the diagnosis of asthma, and that asthmatic athletes are twice as likely as their counterparts to actually earn medals. So as a result of attending this session, I hope you would remember that we are like most sharks. If we don't move, we die. So we need to continue to exercise. Children who experience shortness of breath during exercise are often experiencing just a normal physiological response. But if they are not exercising because of the symptoms, then we want to do a trial of short-acting beta agonist. And if they are non-responders, then we may want to consider an exercise study to evaluate them for additional exercise asthma that's just not being treated, or whether they have exercise-induced laryngeal obstruction. But we also want to consider hyperventilation or deconditioning as a possibility. Thank you.